Hi, I'm Victoria Mull from Contempo Coding, and I'm going to be doing a short training session on coding for skin grafts. To introduce myself, I am currently holding 3 credentials with the American Academy of Professional Coders. I am a certified professional coder, certified medical auditor, and a certified plastic and reconstructive surgery coder. I've held 2 offices in the AAPC, both in the Allentown and Reading chapters, published articles, hosted webinars, taught the CPC prep course. I taught 5 semesters at Berks Technical Institute on medical coding, advanced medical coding, medical insurance billing, and health information technology orientation. I've done pretty much soup to nuts on the back end of billing. I started out in charge entry. I worked on a couple of projects implementing charge scrubbers, practice management implementations, as well as payment posting, insurance follow-up, and of course coding. I've coded for family medicine, for hospital medicine, for OBGYN, general surgery, and then I took on plastic and reconstructive surgery coding, which was an entirely different world than anything else I was ever exposed to. Very diverse, very unique, and engaging. But the unfortunate thing when I took over plastic and reconstructive surgery coding was there wasn't a lot of educational resources readily available, so I was grabbing at straws, trying to get anything I could, but there really wasn't much, and I was pulling my hair out and trying to find things and desperately seeking and looking. And I guess in doing that I kind of fell in love with the specialty. And the next thing I knew, I was on YouTube poring over surgical videos and reading all of the plastic surgery news CPT corners, some ad nauseum. And I was on the beach on vacation reading practical plastic surgery for non-surgeons. I really need to get a hobby. But in any case, plastic and reconstructive surgery is a little bit more diverse to code than some of the other specialties out there. Which, the thing you have to understand about first coding in its entirety at first is we're looking at a system that is assigned, a numerical system, and we're trying to take something that fits into these numbers. But with plastic and reconstructive surgery coding, it's kind of like, here we have paint samples. So each of these paint samples is assigned a number. And assumedly I could go to the paint counter and give them one of these samples and go, okay, well this is the color I want, and they'll be able to mix it up and give it to me. But the only problem is with surgeries, as a whole, they don't always quite fit into these categories, and with plastics it's even more difficult because you wind up with things where you're looking at these and you're taking paint samples that aren't even close to what you're doing and trying to match them up, and I might think these 2 match, and Medicare is going to tell me, no, they don't. And with plastics you wind up getting these cards and you're looking at them and you're going, first off, oh dear Lord, is that a bloodstain? But let me reassure you that bloodstains aren't really going to affect your reimbursement, so if you get them on your op notes, don't even worry about them. But it's a little convoluted of a process, but it's manageable, I assure you, manageable. So what I'm going to do today, to avoid having any other further coders in the world going and pulling their hair out like I have over how to code some of this stuff, I'm going to do some short video presentations on YouTube and post them on my website so you can see how to get the definitions and the clarity on how these procedures should be coded, at least based on my opinion and my research that I've done. So today we're going to be discussing skin graft coding. One of the first things we need to know when we're coding a skin graft is, first off, what is the type of graft? Is it going to be full thickness skin, split thickness, tissue cultured? Is it going to be replacement skin? And secondly, we need to know what is the size of the surgical preparation area, meaning essentially the wound bed, which needs to be documented in square centimeters, total square centimeters. as well as the size of the skin graft, so how big is the graft that we're placing, and where are we placing it, what is the location of the recipient's site. Sizes for skin grafts are grouped together based on whatever body areas they list together. So if they say trunk, arms, and legs, and you're putting 3 grafts on a trunk, an arm, and a leg, you can combine those together for the total square centimeters, and that's the square centimeters that you would use for coding purposes. So it is best to list just the total size and not say, oh, it was less than 25 or less than 30 or less than 40, because the sizes change based on the type of the graft. For example, our split thickness skin grafts, they're based on 100 square centimeters, and they're broken down basically to 2 sections of body areas. The major larger areas, trunk, arms, and legs, and then the second area would be our smaller, more intricate areas, the face, scalp, eyelids, mouth, ears, genitalia, etc., etc. The other thing you have to note is it does say 1% of body area, but that only pertains to infants and children, and by children they mean patients that are 10 years of age or younger. That is when you only go by that 1% of body area or part thereof. Any other case, if it's patients that are older than 10 years of age, that's when you go by 100 square centimeters. And each additional 100 square centimeters, you use that add-on code. So if you're doing 400 square centimeters, you would use the 15100, for example, for a trunk, and then for each additional 100 square centimeters, you would use that 15100, so you would add the quantity on. Now, when I saw first that split thickness skin grafts and full thickness skin grafts were 2 totally different amounts, my first impression was that CPT was just trying to get me to trip up and bill things incorrectly. But as I kind of delved into things, I found out that basically full thickness skin grafts are done on a smaller scale generally than a split thickness skin graft. So when we're talking reimbursement, of course, we're going to have to reimburse them based on a smaller scale. So these are even broken down even further. So the trunk, for example, is 1 code, and then we have ones for forehead, chin, etc., etc. And then if we're doing something on something really delicate and intricate, again, that's going to be a whole separate code, because we're going to want to reimburse extra if you're doing a skin graft on an eyelid versus a skin graft on a trunk, because there's obviously a higher level of complexity involved. Now when we get to the epidermal autografts and the dermal autografts, they're almost identical, 100 square centimeters or less, trunk, arms, and legs, and then the second code is going to be broken down by face, scalps, eyelids, etc., 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 and they're the 100 square centimeters, and again, the 1% of the body area. So not too difficult to pick those ones out. Then when we get into the skin substitutes, they just set up a whole new set of rules there for you. Essentially with skin substitutes, you would need to know if they are 100 square centimeters or less, or 100 square centimeters or more. And then the codes break down for the first 25 of the 100 or less, and then the 25 at each additional or part thereof up to 100. So, you know, they're essentially broken down between 2 body areas and then 2 totally different units of measurement. So you have to really be careful, and again, this is why I say, don't just say it was 100 square centimeters or less, or 20 square centimeters or more, because it's easy to get confused, so providers really need to be aware that it's best to just document the total square centimeters. If you want to say it was 10 by 10, and then, you know, the coder can go from there and calculate the square centimeters, or if you just want to give the total square centimeters, that would also be acceptable. Surgical preparation, if it's just a simple occluding, or if you're removing an old graft, that's all included. But what we have to understand about these surgical preparation codes for the cleaning of this wound bed before we place the graft is it states that these are only down to and including subcutaneous tissue. So if we're doing debridement to prepare for the placement of a graft, and we're doing it down to the fascia level, we would basically have to go back into CPT and dig up our debridement codes. So we're looking at, for fascia, it would be like a 11043, 11046, and those are based on 20 square centimeters. And you would have to essentially unbundle them, because Medicare does have a CCI edit on them that they are, under most circumstances, considered bundled. But considering it's very clear in the verbiage here that these only include subcutaneous tissue, anything deeper than that really should be appropriate to be unbundled. Now, with the surgical preparation codes, one of the things it does say here in CPT is that the surgical preparation codes are to be used for placement of an autograft, flap, skin substitute graft, or negative pressure wound therapy. Now, it's interesting the part about flaps, because CPT's definition of flap versus what is clinically a flap is quite different, and actually the verbiage among CPT isn't even consistent. Clinically, any piece of vascularized tissue is considered a flap, but per CPT they actually have very clear definitions. There is a category right here that says flaps, skin and deep tissue. And then there's a section after that, other grafts and flaps. So anything that's under those categories really is considered a flap, short of what we refer to as adjacent tissue transfers or rearrangements. They are actually, per CPT, not a flap, because they're not under those little categories that are subheaded flaps. They are called adjacent tissue transfers. So within CPT, they'll say things like, you can code separately for a flap, but when they say that flap, they're meaning what they have under that category of flap. They actually don't refer to adjacent tissue transfers in those inclusions. They will sometimes say things like, you can code separately for a local flap, and presumably those do mean the adjacent tissue transfers, but again, the verbiage is very inconsistent, so sometimes it's hard to tell. Like the hidradenitis codes, they say you have to code separately for a flap, but the codes for the adjacent tissue transfers, the local, the Vito-Y's or whatever you're doing, they bundle in. So you actually have to bill separately just for a flap code instead, because Medicare won't let you bill the hidradenitis with the complex repair, for example, and one of the codes from the 1400 series for the local adjacent tissue transfers. Now, if you have any further questions, you can feel free to contact me. My email is victoria@contempocoding.com.